Welcome back, or welcome if this is your first time visiting. My name is Tina Hurley. I'm the founder and executive director of Less Leg, More Heart, nonprofit that serves the disabled community, amputees specifically, with support supplies and services that improve quality of life. This is Heart to Heart. We meet the second Thursday of every month at 6 p.m. Eastern, where we bring health and wellness experts to the comfort of your own home or have limb loss specific topics that we cover so we can hopefully help you stay as connected to the community as possible, have the best resources and education as possible so you can live your best life on the one or none remaining legs that you have. Life can still be so beautiful together. So we've got a really awesome segment today, which is so exciting. We have a group from Northeast Rehab here tonight. We've got some incredible experts. I'd love to introduce them to you all after a quick housekeeping. We'll just make sure, because we do have so many wonderful people here today, that we keep our microphones muted unless we need to talk, and take advantage of that hand raise option. I do have an incredible amputee that's running the chat. You all know and love Erica. So if you have anything specific that you have for questions or things you want clarified, or maybe you want to ask something but you're not comfortable, please feel free to go ahead and just direct message Erica Kinney, and she'll be your voice for you today. So we're really excited to jump in and introduce you to your experts for tonight for our Ask an Expert panel with Northeast Rehab. We've got, in no particular order, a medical expert, Dr. Donald Tower. He's a DO, and his name precedes him. I've heard all about Dr. Tower on the streets and all of the incredible patients that just can't stop singing his praise. And we also have, with prosthetics, we have Paul Harney. He is a CPO. For occupational therapy, we have Rebecca Pritchard, and physical therapy, Danielle Potter-Doobie, and nutrition, Zach Navo. And we're really excited for you guys to meet him. So drop in the chat where you're from, what your amputation level is, perhaps the reason that you're here. Are you experiencing any challenges right now in your life as it pertains to medical, prosthetics, OT, PT, or nutrition? And or what brought you here tonight? Are there any specific things you were hoping to solve? Because these are the brains on board to help you solve it. I would love to have some conversations, and I'll open it up first to each of our experts here with a guided prompt for them to start helping you get to know them and their expertise. And Dr. Tower, not to put you on the spot, but I was hoping that you could share some information about what the most overlooked medical factors are that affect the long-term health for amputees, and what patients should be thinking of or monitoring proactively.
All right. Well, first of all, thank you very much for having us here. It's really a great honor to be doing this with you all. Yeah, great to get out and about and whatnot. We get locked in our caves for so long; it's hard to get out in the community and whatnot. Um, yeah, I think a couple things. So background with this, the reason I ended up getting more involved with this prior to coming to Northeast Rehab. My background was polytrauma. In addition to a lot of the different fractures and brain injuries folks dealt with, we worked a lot of individuals, active service members with limb loss. And I got to work with a lot of folks at the VA hospital in Richmond, Virginia, and amazing work that they did there. So it's really excellent to be able to take that experience and then bring it up at Northeast Rehab and bring it here. And then going right into the question that you had mentioned, the most overlooked medical facts is not really overlooked. It's talked about all the time, but it's the most pertinent. It's the most studied. It's the most talked about there. It's diabetes. Diabetes management, blood sugar management. It affects every single organ system. Diabetes itself there, it's if you want to look at it, everybody's like, it's a blood sugar endocrine disease. No, it's a vascular disease. It affects every single part of your vasculature. It affects your heart. It affects your kidneys. It affects peripheral vasculature overall. It affects nerves. And maintaining appropriate hemoglobin A1C over time has been shown to decrease overall morbidity, mortality, the whole 9 yards when you're talking about skin healing. Anything along those lines, number one thing overall that folks need to be doing, proactively monitoring, making sure you stay on top of it. From not just I took my insulin today, it's a multifactorial type of approach there. It is, what type of diet do I have? What type of exercise am I able to do day in and day out? Do I have the appropriate physicians in some cases there, but again, dietitians as well. Zach's here. and different things. When dealing with limb loss too, if there's issues with the prosthetic, are you talking to your prosthetist? Do you need to be seen by a physical therapist to make sure that your exercise regime is appropriate? Um, all of which then leads towards appropriate hemoglobin A1Cs. There are other things that are big factors as well. Smoking cessation is a big one. That's a big one all the time. But the biggest one is diabetes.
We might have had a little lag, but we hear you, Dr. Tower. Smoking cessation is where we lost you.
That's about it right there too. Otherwise, I'll just keep motoring through, and Lord knows you guys don't need to hear that.
Oh, it was wonderful. And actually, we have some of your former patients in the chat that are continuing to sing your praises. So it's
Great.
amazing. You seem to make quite the impact on the community.
Okay. Well, thank you for saying that. Thank you.
So, Paul, maybe you could take the spotlight now and share your perhaps background in getting into it. That was wonderful context from Dr. Tower, and share maybe what innovations or habits most improve comfort, function, or fit for prosthetic users.
Well, hello. I'm Paul Harney. I'm the president and owner of Prosthetics, my FDR center, and I have an office in Nashua and in Burlington, Mass. And I spent a lot of time up at Northeast Rehab in Salem as well, and very much enjoy my work. Um, I've been at this work for about 40 years now, and so that explains some of the gray hair on my head. Um, but getting to your question, fit is the most important thing I would say in terms of a prosthetics user, especially as Dr. Tower was mentioning, the diabetic patient. A lot of the patients get into the amputation because of issues with wounds, and so when it comes down to be wearing a prosthetic limb, it's most important that they can stabilize their volume, and that the prosthetic limb's constantly being monitored by the patient to be looking for sores and irritations, and being addressed by the prosthetist. Um, Getting to some of the innovations that are available right now, there are some adjustable sockets that folks are starting to use, and we're using in our practice, and there's a number of them. And so it's very exciting for the patients, because prior, you needed to take your limb off and add socks and things like that. But we've got some various different type of technologies available to the patients, and it's not always the right answer for everybody, but it's certainly something that you can learn about and ask your prosthetist about. Um, there's a very uh, new thing that's called the Martin Bionic socket, and it's got a kind of little bit of a adjustability that's almost like a ski boot buckle, and we can adjust the volume for the patient, and that's been very good, especially for folks that have oddly shaped prosthetic limbs. For folks that are very large distally, it becomes difficult to be able to apply your prosthetic socket and have a snug fit proximally. So I can show you that in a minute. Also, there's the new sockets that have little dials on it. They call it a click system, where there's little windows in your socket, and we can turn the dial, and that's a very simple, streamlined solution. And I have a lot of folks that they put on their prosthesis in the morning, and by the time they get to lunch, it starts to feel loose, and or they're doing an activity that's requiring a lot of physical effort, and they lose volume in their prosthesis. And what are they going to do in a situation like that but have to remove their prosthesis and saw? I had a gentleman one time, one of our patients, that his major focus was, I want to be the guy that can golf again. And so I couldn't wait to play golf with him. We got out after 9 holes on a sunny day. He needed to add a 5-ply sock right in the middle of the round. And I thought, wow, that's a lot to add in one shot, buddy. But that's what he needed to do. And now he's got a click system, and he can just turn a little dial on the socket and tighten it up. So there's a lot of little things now that are available, and I still will support sock ply. I believe in it, and wearing your shrinker at night is still a good thing, especially if you have a lot of fluctuation.
Thank you so much. I'm sure for each of you specialists coming in, there's so much to the question that I can see, the reservation and just trying to pull those niggle nuggets forward. So I can
Right.
appreciate the hard work you're doing with all of your experience.
Thank-
Thank you so much. I would love to go over to Rebecca next, occupational therapist, and perhaps you could share again any background and what got you into the sort of thing, and how can daily tasks be adapted to promote independence and reduce frustration?
Hi, everyone. I'm Rebecca. I wanted to first say thank you for inviting us. This is a cool forum to be part of. Nice to get out into the community, a little bit different than seeing patients every day in the hospital. So that's nice. So I've been with Northeast Rehab for, I think, going on 12 or 13 years. So a lot of experience working with patients, usually right after an amputation, but also patients that are in the hospital for different reasons and happen to have that in their past medical history. So as getting to the question, I thought this was a broad topic, so I kept it kind of broad in my responses. The main things I usually work on are energy conservation and how we can adapt a task so that it meets your needs, and finding what's important to you, so you have that energy to do those tasks. So talking about energy conservation, some tips I would say are making sure that you plan ahead. I think of this with the cooking task. So organizing all the ingredients that you need, so we're not going back and forth and wasting a lot of energy doing things that's not really important to you. Preparing before you start, taking breaks to avoid fatigue. So if you need to do something sitting, do that instead of wasting your energy standing for the task, like cutting vegetables or folding laundry. In the kitchen, doing little things like buying pre-cut vegetables, using smaller containers, there's not as heavy to lift, is another way to save energy. Sometimes doing a big like crock pot meal I think of, so then you have that for a couple of days. You don't have to be cooking every night. Another room of the house, thinking of in the bedroom. Sometimes I've had patients to save energy. They'll take the clothes right out of the dryer, so they don't have to hang up their clothes, put it away every time. All the clothes are right there. Just another way to save energy. Choosing clothes that are easy to get on and off. I know I talk a lot with patients about maybe going up a size so it's easier to get the shirt or the pants on. Elastic waist is sometimes easier as well, depending on dexterity. Sitting to fold clothing as well. I know they have adaptive sheets. Sometimes that's easier. A lot of adaptive clothing. I think I've seen them even on Target, so it's a lot more accessible. And then also using adaptive equipment. I know we hand out a lot of long handled reachers, which are good to save energy, but also as a fall, decreasing a fall risk, so you can access items a lot easier. Let me see what else I have. Moving items, I think, so making the environment work for you. So moving items that you use a lot, that are at a level that aren't way up high or way down low, but are easily accessible. So you're not, losing your balance trying to get something or lifting something heavy from a lower surface. And I would always recommend also looking after your own emotional well-being, right? There's going to be frustration. You're learning how to do something and you're having to learn how to do it a little bit differently. So give yourself some grace, give yourself a lot of credit, and celebrating those small wins, and seeking support where you need it, whether it's a support group or talking to therapists, I think is also important. And then just making sure that you stay active and healthy. I know we give out a lot of home exercise programs, just trying to incorporate that into every day.
Awesome. Thank you so much. Yeah, these are intentionally sort of vague enough that you as the experts can choose what you respond to. I love the open-endeds because it really pulls out the direction. Thank you so much. That was a really well-rounded thing. And to your point about energy conservation, we've had a significant talk about this in the past. In fact, I remember when Cindy was on last, we talk about having this battery. And I feel like we're not as aware of the battery, or I wasn't as much when I was a two-legger, right? When an able-bodied. And now I can do the things, but at what depletion and at what payment on the other side of things. And so that topic really resonates with our group. Thank you. And then Miss Danielle Potter, we're a physical therapist, and I was wondering if you could share with the group exercises or movement strategies that help prevent secondary pain and maintain balance?
Thank you again for having me. So my name is Danielle Potter Doobie. I've been working with Northeast Rehab for the last 11 years and ran the orthotics and prosthetics clinic in Salem, and now I'm in our Portsmouth office, and I'm an outpatient physical therapist. So I am seeing patients with and transitioning to use of a prosthetic and teaching how to use a prosthesis and how to walk with that. So I've enjoyed that thoroughly for the last 9-10 years. So when I kind of read this question, of course, I have a huge amount of exercises and everything, but the first thing would be, of course, everybody should be talking to their physical therapist and what is appropriate for each and every person, what your goals are, because that's really what ends up kind of creating that program for you. But for the biggest ones, for everybody, I would say it would be hip flexor stretching, which is the anterior hip. You'll hear a lot of prosthetists too initially saying lay on your stomach. We have some other ways to get at it, but yes, one of the best ways to do that is laying on your stomach. And for the reason of that is that your hip flexors are actually attached into your low back. And so when we go to stand, that will pull on the low back, which will cause low back pain. And then we also need that hip flexor to be stretched out so that we get nice long steps when we're up and walking. But it's really easy to get them really tight because we're sitting for the most part while we're healing after an amputation. So leading to the next part of on the other side of the front of the hip is the glutes. No matter if you're below the knee or above the knee, the glutes are now your biggest source of stability on top of course, your core muscles, but they're your reactors to balance. So any sort of glute exercise like a bridge, things like that to start off with, and then kind of going forward into a more functional exercise if and when able. Sit to stands. Love sit to stands because they're so functional. It's like doing a squat. We do them all the time, and you get to utilize all those functional muscles in a really good way. And the biggest thing I usually tell my patients too is you've got to integrate these exercises into your daily routine. Kind of going through kind of what Rebecca was saying too was, yes, have to choose when you can do it. Can you do all your exercises at once at the beginning? No, you have to kind of decide, all right, I have this much energy, I have to do this task and choose that. But hey, if you have to get up to go to the bathroom, can you do 5 sit to stands? Work them into your day. It's kind of the best way I find people to do things consistently. The other piece would be having the appropriate assistive device to prevent falls. Knowing, should you be on a walker? Should you be on a cane? Should you be with crutches? And again, that's a question for your physical therapist or experts that you talk to as you're going through the process. And again, I could go on with a lot more, but the biggest thing is keep moving. The more motion, and everybody can move. And that's something we talk about. I do run our support group as well. We talk a lot about that there's, chair exercise, chair yoga groups, things like that we don't have to be walking and standing to do, but we can find ways to move and move functionally and to be able to reach your goals. So.
Wow, Danielle, what a wonderful wealth of knowledge. And it's so true. I didn't walk for 18 months after my amputation, which was 3 years of surgeries. And everybody here has a similar, sad story. And the benefit of simply just doing like the couch stretch thing for the front of my hips was revolutionary. We take for granted some of those things that don't give us endorphins. And it was so crucial. So thank you for making it simple to understand and very targetable. Really appreciate your input. And then last on our panelist list is Zach. He's our nutrition expert tonight. Zach, do you mind sharing a little bit about yourself and also talking about how nutrition influences healing, energy, and pain management after limb loss?
Yeah, so I'm Zach. I've been a dietitian here at Northeast Rehab for about 6 years. So I'm mainly seeing people inpatient. We don't have any outpatient education here. So mostly I'm seeing people post-operative after their amputation. But like before, there are people who get admitted that have a prior amputation. So obviously I talk to those people as well about that. Nutrition for amputation kind of needs to be broken into an immediate post-operative nutrition and then long-term nutrition, because there's a huge difference between your energy and calorie and your general nutrition needs after a surgery than in your everyday life. So here at Northeast Rehab, I'm often focusing on protein as the most important thing after an amputation surgery, because we're worried about wound healing. We want to make sure wounds heal well after surgery and don't become chronic wounds. And probably the biggest thing you can do is eat extra protein. Your protein requirements are higher when you're healing, because if you think about it, you're making all kinds of new skin, and skin is your biggest organ in your body. So if you need to make all that new skin, you need to get extra protein so that your body has the resources to make that skin. On top of that, usually I'm talking about people about extra calories, because a lot of people, especially people here, are at Northeast Rehab, they're exercising with their PT and ROT every day. Obviously, right after the amputation, that's a lot of exercise for them. That's a lot of energy that they're burning, and their body's also burning energy healing, right? Making new skin. So it's mostly like high calorie, high protein right after amputation. And we're always pushing supplements and eating more. You really can't get too much, right? Because we're not really worried about weight management when someone's in rehab for a couple of weeks. We're mostly worried about them healing and getting better so they can get out of here. Vitamins and minerals and stuff like that are all very important. There's so many different vitamins and minerals that contribute to wound healing, like vitamin A, D, E, K, etc., vitamin C, all kinds of minerals, zinc. The good part about that is you don't really have to worry about that much. Pretty much all the studies show that if someone's eating enough protein, enough calories, they're eating enough foods, they're eating a variety of foods, they're not going to be deficient in any of those vitamins. It's not going to delay wound healing or anything like that. Yeah, the printer is going to happen every now and then. So you don't really have to worry about that stuff. If you were even concerned, you could take, a multivitamin. Pretty much all protein supplements have a multivitamin in them. So we don't really have to worry about that. So we mostly just worry about calories and protein. Long-term nutrition requirements are pretty similar to someone who hasn't had limb loss, which is a good thing. There's no specific diet that you really need to follow long-term. Now, as Dr. Tower mentioned, why you lost that limb is going to matter, because diabetes is a very common reason. So obviously, if someone has diabetes, cardiovascular disease, renal disease, long-term, the diet that they're going to need to follow is going to be based on their comorbid conditions and stuff like that. It's going to be based on individualized care plan, talking to doctor, dietitian, something like that. They'll be able to let you know if there's any special diet that you need to follow. But if there's nothing like that present, then long-term, there is really no specific diet you need to follow. One big thing long-term that we worry about is weight management. When someone's fresh off their amputation, they might not have a lot of mobility. They might be more stationary. They could gain a lot of weight. If someone has a prosthetic where they're using a wheelchair and they're still very active, they could possibly lose weight, because using a wheelchair burns more calories than walking. So if someone's very active, they could be losing weight. So we don't really know if someone's going to lose or gain weight after amputation. So again, it's very individualized, but we want to make sure people are able to maintain their weight well. When you talk about like prosthetic fit and stuff like that, we don't want someone unexpectedly gaining 20, 30 pounds or something like that, because that can really affect the fit of their prosthetic. We don't want someone losing 20, 30 pounds for the same reason, but also just because that might be an unhealthy weight loss. They're going to lose some muscle mass and stuff like that. That could affect, getting around. So mostly we're focusing on protein right after amputation. Then long-term, we're probably focusing on weight loss and then treating any kind of other conditions that they have that might have led to those amputations.
Amazing. Thank you. What a wonderful conversation. I do have a quick follow-up question for you as we're getting into discussions. First, I'll let everybody know that this is going to be your time to jump in, share stories, and ask the experts questions directly. So if you want to do that in the chat or you want to do that in person, go ahead and hit the hand raise function so we can start calling you off. And while you're doing that, I was wondering, is there a specific, we hear so much stuff out in the community about protein requirements, right? And so I have an idea, just because of my background, in what I think that might be, but you're probably more current with the research. If somebody is out of the inpatient facility where that's going to be likely managed by the team, What would you think that they should be shooting towards? Everyone's different, I know that, but is there sort of a goal range, and how can people start to even understand what that means? We have so many people that when they're like, oh, the doctor told me to increase protein, I go, okay, so what does that mean to you? And they're like, oh, I'm just gonna have some more chicken at dinner. And I said, well, where are you at right now in terms of protein intake? And for a lot of people, it's not super common. So can you walk folks through sort of like how to first identify macros, perhaps how to quantify it, and then how to increase it in an easy way?
Sure. So protein requirements, as you've mentioned, are going to be different for everyone, but we can give some general recommendations about an amount that's probably going to meet most people's needs. Again, if you have active wounds or something like that, you're going to want to increase it. So the big way to do protein is we do grams of protein per day per kilogram of someone's body weight. And if you want to figure out how many kilograms of body weight you are, which is obviously not a measurement we use a lot in the United States, you can divide the amount of pounds you are by 2.2, or you could just look it up on Google or something. That gives you your kilograms of body weight. And then we tell people to eat a certain amount of protein per kilogram of body weight per day. So for example, if someone weighed 60 kilograms and we want them to eat 1 gram of protein per kilogram of body weight per day, that's 60 grams per day. And so all our recommendations are pretty much going to be like that. I think a good amount for the average person to eat is somewhere around 1.0 to 1.2. The Academy recommends somewhere around 0.8 for most people, but as people age, the requirements go up a little bit. And there's really no issue with getting too much protein. A lot of recommendations I see online for bodybuilding are 2.2 grams per kilogram, which is way overkill. And those people don't necessarily have any health problems for that. So you can't really go too high. So I would probably recommend like 1.0 to 1.2. And that's going to look like for someone who's female, somewhere around 60. For someone who's male, probably somewhere around 70 to 80. Again, it depends on your body weight, but that's just the general averages. And how you would incorporate that is you're going to have to look up, how much grams of protein are in the things that you eat. Sometimes people might feel comfortable getting an app. Like there's like free ones out there, like Calorie King and stuff. A lot of the free ones might have user submitted data, so you don't know how accurate it is. But, if you're cooking stuff yourself, you could look up on the packages, on the back, on the nutrition label, how much protein or stuff. So maybe you have a better idea. But generally, something like a chicken breast, you could probably find pretty accurate information online. A chicken breast, depending on the size, might be 20 to 30 grams of protein, right? Depending on how big it is. So if you're having something like a chicken breast for dinner, and then you're having protein like a yogurt that maybe say has 10 grams. Someone in the chat mentioned MyFitnessPal. There's all kinds of apps, and they're going to have somewhat accurate data. You just want to be careful if you see some sort of value that's outrageous, like it says something has 100 grams of protein. You got to check that, because like Wikipedia, if users are submitting stuff, there's going to be errors. It's not going to be checked. So generally, if you're having protein on each meal, you probably are meeting your protein requirements. But if you want to be careful and you want to be specific, then you want to track it with an app, and you want to kind of, or even yourself in a journal, just write down what you had. If you really were concerned, you could bring it to a dietitian or a doctor or something like that. I'm sure they could help you figure out the amount that you're eating. So
Awesome. Thank you so much. And so I've seen some hands go up. We'll go ahead and start with you, Erica.
Cool. Yeah. So I've been monitoring the chat and a few different things here. So Jeffrey Faulkner has commented twice. The first was about he ran a 5K on Sunday and he had to stop to drain his socket, add socks, and get back on the course, which meant he lost his position in the race, which must have been super frustrating. But without that, he was pistoning and wearing a blister. So he had to pause and take care of that. And then he also said that he has had some issues with his weight since his amputation. He's gained a lot of weight and he's been trying to watch what he eats, going to the gym, moving as much as possible, but he's now pre-diabetic with high blood pressure. And he's been talking with his general practitioner about weight loss, but that has also been a big struggle.
Thank you, Erica, for sharing. And Jeff, thank you so much for your transparency and for the strength in your vulnerability. These are really great talking points, and your feelings are shared, I'm sure, among a lot of us. I'd love to open it up to the panel for any insight or feedback or thoughts that you might have related to some of the challenges he's facing. And no particular order, you could just unmute and yap.
I will say that I walked briskly the 5K. I did not run the 5K.
Well, that's okay. Good for you for getting out there, Jeff.
It was the Bionic Project 5K that was in San Francisco this weekend.
Excellent. So my question directly, and maybe this will work easier, Dr. Tower, when folks are presenting with refractory weight struggles, despite seemingly doing all of the things right, and perhaps this is also with PT and nutrition, are there any suggestions you have in terms of tests that could be run or rocks that could be turned over? Does it put your antennas up for anything in particular?
Yeah, I think sort of at that point would want to start at square one in the sense, sort of looking at all the different potential medical issues that are ongoing. When you're thinking about weight in general, different things with weight gain, some of the basic. So, all right, as we all age, our metabolism goes down every year. That's one part of it there, but it doesn't necessarily mean like I gain this much weight just because of that. That needs to be checked more so with typical type of thyroid panel testing would be starting point with it right there. If there is fluid gain and things along those lines, I would want to be really careful to make sure there isn't any other sort of underlying. And Jeffrey, I want to be really clear. I'm not saying this about you, so I'm talking about in general. Is there any sort of underlying heart failure type of issues ongoing? Those are two things right off the bat where you'll get, especially heart failure, a lot of fluid fluctuations, quick weight gains and things like that. However, that usually comes with a whole bunch of other symptoms and whatnot. We were talking about in the run there with some of the pistoning. I am going to point at Paul here with some of this as well. But again, my question with it there too is how much variability would you have day in and day out in terms of the residual limb having some fluctuations in around it there too. When was the last time the socket was checked? And is the socket set appropriately? And again, get it to defer more to Paul with this for something like a brisk walk 5K, because sometimes the components in the sockets in ankles and whatnot there are not appropriate for something like that. Weight gain part of it there too, jumping the other part. I'm going to defer this one with Zach as well. Exercise is very important. And I agree with Danielle and Rebecca. However, when you're talking weight management and whatnot, a lot of it is what's going in the mouth, not necessarily the energy burned. And again, I'm going to defer to Zach with some of that as well. So Paul first, Zach second.
Okay. Hey, Jeff. So I wanted to ask you, if you don't mind, Jeff, what kind of suspension do you have on your prosthesis? Is it one of those pin systems, or do you use a suspension sleeve? What are you using?
It is a sleeve, yeah, not a pin
Not a
socket.
pin.
Yep.
Yeah. So have you heard of elevated vacuum?
I think that might be what I have. I'm wearing a liner and then a sleeve, the vacuum sleeve. Right.
There's also we can manage the vacuum mechanically as well. There's a little gadget you can add on your prosthesis.
Yep, I did have that, and where the liner met the sleeve, it actually lifted my skin up and made a huge ring. It was getting so tight that I got like a really bad reaction to that. So I dropped off of the vacuum.
Right. All right. Well, maybe that's not such a great idea for you. Sometimes something like that, because of the elevated vacuum, it'll expand your limb and it prevents it from reducing, right? But it's funny because it reminds me of the story I was telling about the golfer, right? In that after playing 9 holes of golf, he had lost all that volume. It sounds like you get halfway through your 5K and you've kind of shrunk yourself out, right?
Yep. So for me, I start with 10 socks to 5-ply socks, which is pretty high already.
Yeah.
And then I have a half sock that I wear, which is another 5, because I can't put all that on my knee, the joint there. I couldn't put another sock there, but I can fill the base. What do you call that? The distal end.
Yep.
I can't fill that at the knee. So I cut it in half and fill the bottom. And then I have another 5. So I say I'm wearing 15 socks, which last time I talked to my prosthetist, he said 15 was way too many. So at some point we may need to do that, a new socket. And then I know that my liner and my sleeve are both worn out. There's holes in the vacuum, there's holes in the sleeve. But that's because my insurance has changed and now I'm on the hook for DME for 40%, right? So I don't want to buy new sleeves. I don't want to buy new equipment when it's going to be extremely expensive and I'm on the hook for that. So I try to make it last as long as I could, but for a 5K, I probably should have swapped out all the equipment and gotten some new stuff there.
Also,
Right.
Jeff, do you sweat a lot typically
When I
in warmer weather?
exercise, usually I'm okay when I exercise, but when I'm doing a 5K specifically in the leg, yeah, it collects a lot of water. And I do have a antiperspirant that he
Okay,
prescribed to me. So again,
you're doing
if
that.
if it wasn't like 4 o'clock in the morning when I had to drive all the way to San Francisco to get to this place, I would have thought, oh yeah, I need to put the antiperspirant on before the race. That would have been a good thing too. So a couple things to catch me for the next race.
All right. Any other thoughts from the panel? I know that while you guys are thinking, and this, I am not the expert tonight, but you guys know I have a medical degree and was amputating legs for a living and became an amputee. So I have somewhat of an accidental dual side of the bed situation here. When I think of that much ply, Jeff, from a user perspective, I think for sure I'd talk to my prosthetist about casting, just to shrink that down if it were me. And then I also think about the role of, because I can totally get, it's almost end of the year, your insurance is resetting, that would be silly to out of pocket all that cost. But is there any role for some of these products on the market like Sleeve Saver that can patch holes? Have you heard of that product before, Jeff?
I've actually just used needle and thread. So when my cat jumps on and starts shredding my my sleeve, I use a needle and thread and put it all back together again.
You
So
know,
no, I haven't put anything on the
yeah,
the rubber liner side, but I
yeah.
have tried to hold it together.
There's a
Um,
product that I found at the, and please drop comments in the chat too for anyone here that has lived in user experience for things that might help folks with certain situations. Sleeve Saver is one of the companies that actually creates this like tape-like situation that's silicone. And so you can patch the liners just to help with the holes in the system temporarily. I don't know about like long-term durability, but it sounds like this is a short-term issue anyway. So check out Sleeve Saver. And then also EthnoCare is a Canadian product that makes a pneumatic sleeve that inflates, and it's supposed to be 2 to 15 ply. And so for some of our active athletes that do races, Sam Schaefer, for example, he would use that when he would go on runs because he would drop like 5 or 6 ply, just in the first few miles. And so, maybe there's some products out there. I don't know if the experts here have any familiarity with those or have any other vetted things that might help him.
my use of the 5K is more of that motivation to keep me walking. I'm not a runner by any means. I have a Flower All Pro leg just for my exercise, but I don't have a running blade. This is just I've got a target. A couple times a year, I'll try to sign up for one, even just knowing that the training and the exercise to get there is important as well to keep me motivated. So um, there are some things that I can use, like you said. I certainly should have replaced because even the elasticity of the sleeve is getting less, right? It slips down all day. It's not just the vacuum is lost, but now it's not even really tightly hugging my leg. So,
Yeah, Jeff, it's so interesting. This is a great vignette about, the multifaceted challenges that we face, right? From like the weight to the medical comorbidities to the athletic and prosthetic related challenges. And then you link in billing and some of the insurance barriers to even getting the things that could help. Like this is a very good example of how complex of a landscape and how many people have to be involved to fix the different things for you to be optimal. So I really appreciate you sharing this as a conversation piece. And I'll connect with you offline because obviously we're a source for some funding, and I would love to get you a running blade and get you the things you need in the interim. Mr. Harney, do you happen to know what the average duration is of the sleeves in your experience?
That's always a difficult question, and it's because people just bang their their prosthesis into the side of the table, and next thing they have a hole. It's awful. You know, there are gaiters. I don't know if you ever tried one of those, Jeff. It's like a little lining to help protect the edge.
I do have a
You know?
gaiter, yes.
Yeah, I will say though, once you get a hole in that suspension sleeve, it's over in terms of that's why it's sliding down. It's terrible because you lost all your suspension. So sorry about that, you know, but I have patients that they'll even cut little patches from one of their other sleeves and kind of put the sticky side against the hole on the inside, and that seems to get them through with some of these things. And you know, you can buy suspension sleeves online. I don't know if you save a whole lot of money because what we get reimbursed on suspension sleeves is about what we pay for them. You know, of like a little $100, $120, numbers like that on suspension sleeves. They're not terribly expensive, especially when you're doing a sport and you're buying running shoes and things like that. But you can't be losing suspension on an activity like running. It'll really hurt you, you know.
Yeah,
Well, here's
yeah.
something that I didn't consider as well, is I have no idea how much these cost. I actually have a box sitting in my, at my house with a brand new one. I just was given one when I got my new socket, and I said, well, I want to make these last as long as possible because I have no idea how much these are.
Right.
I got the bill for 20,000 for the leg and all the accessories, but how much that one thing was, no clue. So
Yeah.
You know, and Jeff, you're not alone. You know, I can see everybody here nodding their head around, and I've been an amputee for 9 years. I recently fell into it's convenient for me to do this sleeve. For those that haven't seen it, it's the Oster Seal-In Iceros sleeve, and it's not for everybody, right? Everything's super individualized. Talk to your prosthetist, obviously, and your team about what works. I like it because the knee bulk that you're talking about, Jeff, in terms of having the liner, and then you have all the sock ply, and then you have the sleeve. For me, I needed an enhanced range of motion in my knee more than I needed the extra security, which for my day-to-day made sense. But the fault on that is that there's holes that continue to start cropping up in the seal because I've gone and doffed my leg so often. So there's no one good answer, and it's all trial and error. And with the right team and the right sort of brainstorming, and it's all just such a trial and error. And I know in my beginning of the journey, I was a fast person and I wasn't a builder brain and I wanted to go, go, go. And the amount of change that's occurred in 9 years to pace and to think ahead, and like your occupational therapist said, to set everything up in advance. And do I have my silicone patch goo with me when I travel, so if I get a hole, I'm not stranded? There's so many of those pieces. But Jeff, we're going to connect offline because I'd like to remove your financial barriers to getting moving, and that's sort of what we're in place for. So thank you for sharing. Go ahead, Erica.
Okay, so I've been monitoring the chat. We've got a few things going on here. CK Shaw said that she uses a cart, a rolling cart, to put things from her counter onto the cart so that she doesn't have to bend over as far to access things. And even now that she's not in a wheelchair, it still helps her to not lose balance. So that is a great point. Hopefully that was a good synopsis. And then also Tim O'Toole says that the largest surprises I've had have been with repetitive stress type injuries from assistive devices, wrist, elbow, shoulder pain from forearm crutches or canes, etc. Every time mitigated by fixing whatever body mechanics I was doing wrong while working with PT, and fortunately never got to the point that it prevented them from doing anything. And it seems like dropping down from a single cane this year, developed foot pain, etc. And so I think, ongoing stress fractures, x-rays, and PT has really been the biggest impact, improving range of motion in ankle and calf, and just big fan of PT. So I don't know if anybody if you want to have a discussion about that, or if I've got more.
Yeah,
So
no, I
look
let's
to what to
pause there
do.
because that's a
Yeah.
really good point. And Tim, I'm so glad you're here. I think so many of us are educated, or at least partially educated, about the outcome of limb loss, right? Or we understand we're going to stand up if we're lucky enough to have one leg, and we're going to be on one leg, and then we're going to have these crutches, or we're going to be in a wheelchair, and there's these, you don't get a contracture in the back of your knee because you got to keep your knee straight and stretch your hip flexors. Like there's this protocol for the limb that is now not there. But what a lot of us may not know up front is just how dependent on transferring and crutches and our shoulders we're going to end up being over so many years, and how many amputees have shoulder issues and elbow issues and wrist issues, or fall off and on crutches and have to have a shoulder surgery. So you're totally not alone, Tim. Is anybody here, by a show of hands, just in person on your camera, have a secondary injury in their arms or their other leg if they have one leg down? Yeah. So you can just see by the show of hands here, it's really common. Anything from the specialists, Dr. Toole, in terms of, from the get-go when someone's amputated, ways to improve that percentage of folks affected, and or ways during their limb loss journey to try to mitigate or decrease the secondary strain?
So the short answer is probably not, because we still don't know how to fully understand where arthritis and osteoarthritic pain comes from and whatnot. But I will reiterate a lot of things that were said beforehand in terms of working hard with your therapy team, in terms of looking at, hey, what are the body mechanics here? Becca made a great point earlier in terms of energy conservation. Take a step back here. They actually did a couple studies. They were several years ago in terms of the actual increase energy body expenditure for a particular level of amputation, and it's significantly higher. And again, the more the higher the amputation level, it's significantly higher, like 200% more than your typical body energy use with it before. So utilizing different things like appropriate energy conservation in certain places there too will then likely put different or less stress on your body in certain areas. Working at monitoring the mechanics, both with the physical therapy team as well as with your prosthetist, is going to be very important to make sure that all the alignments are appropriate with it. And then sort of seeing where it is coming up. It was interesting that you mentioned about the shoulder issues there. It's well publicized in individuals. A spinal cord injury, then again, preserve the shoulders. It's not as, again, not as well known with post limb loss there, but again, definitely something that could be looked into. And a little side note with it, I think the biggest thing with any sort of joint overuse injuries and whatnot there, it's okay, how do we take a look at this? Is there a way to evaluate how we're going about doing things day in and day out, and consider approaching it differently. It doesn't talk easy there, but that would be, again, in a situation where I'm talking with somebody there, I'll do the basic x-rays and be like, you know what, you're going to hang out with your PT again. You're going to hang out with your OT again, and try different interventions there. In addition to the prosthetic there, are there other braces that could be considered? Those are the places I'd start.
Yeah, and then to speak off of that is, I mean, people with limb loss, especially if it's one side only, we have an asymmetry issue. It is unfortunate, but there's no way around it. We can align it perfectly and everything, but we do have an asymmetry of even the muscles are being used differently to utilize a prosthesis than your other leg coming through when you're walking or standing and things like that. So scoliosis, back pain, it's so common with the amputee population, which is where we emphasize, the glutes, the core, postural awareness, body mechanics with activities and all of that. Also kind of, sitting posture is key too, and knowing how your prosthetic is built, because especially above the knee amputees, knowing that your socket is underneath you and may not be soft underneath, and you might be side sitting in a way. So that may be an adjusted pillow or a wedge or something that could equalize your pelvis. And then I spend a lot of time in the sense of accepting weight through the prosthetic leg, and trying to get out of the habit of always leaning towards the sound limb, because that's where we get in the trouble with, especially, and you mentioned the foot fractures, I get plantar fasciitis all the time because people are quickly landing on their sound foot when they're walking, and they're not kind of doing that nice heel toe progression and accepting the weight slowly that they're really impacting through the ball of their, or the bottom of their foot, and taking on way too many forces. So that could also be a discussion of, if you're doing that, maybe we're not using the right assisted device and all of that. Upper body, I think, gets also, once people get prosthetic on, the upper body gets like forgotten about. So that's where learning about your shoulder blade muscles and how they support your shoulder, and you're not hanging on crutches and you're using them correctly, or walkers and things like that. Again, body mechanics and posture are the biggest things to try to prevent and prolong these issues. I have a patient right now who's been an amputee since 5 years old. She's, yes, unfortunately got scoliosis. Her limb is smaller on that side because her muscles are not as developed and things like that. But she's doing great, and she's modified and figured things out, which is awesome. But it is unfortunately sometimes part of the process. But there are ways to slow the process down or also prevent it. So as you go, just talk to your therapist, talk to your doctor if you're starting to notice signs of other issues going on.
Wonderful. Such a great example of, with a can-do attitude and the right specialists on board, there's really a lot of hope. And so thank you for sharing that. We do have a number of hands that are raised, and we have a whole chat I know Erica wants to get to. And I can't believe we only have 8 minutes left in our hour. We could have used 6 hours to talk to you guys today. What a wonderful conversation. But I'd love Cindy. Go ahead, Cindy, with your question or comment.
So this dovetails into what they were saying, and that I don't think I'm unique in that our post-op physical therapy is very focused on walking, getting your hip mobility back, and all of those types of things. But pretty much all of us go into physical therapy using some sort of assisted device. And nothing is ever addressed about the part of our body that is utilizing the assisted devices that most of us still use to some extent. Some daily, some every once in a while or whatever. And I would like to see our physical therapy advance to where we're looking at the whole person and everything that goes in after an amputation, and not just about getting somebody walking. It's more than that. So that was it.
No, it's a very good point, Cindy, that, our medical system has so much they're doing, and they, gosh, the patient number they're seeing, and the systems and the reimbursements and the insurance and the administration, and then the protocols. And it's like, gosh, it's so tough to deal with anything that's just outside of what's right here. So I can appreciate all sides of it, but you're right, and I think that's a really good spot for the nonprofit sector and some of these support groups, is to highlight some of the deficiencies we as a collective kind of see, because folks like the Rehab that are wonderful and really proactive in trying to help, that's where change starts, is these discussions. So thank you so much for sharing. Go ahead, Jeff.
So, Tina, thank you for putting this integrated team together. They're absolutely wonderful, and we could spend an hour on each one of them. But Danielle, my question would be to you about body mechanics. My injury was from a motorcycle accident back in 1978, but I didn't get my amputation done until 3 years ago. But all of that time I spent limping, and since the amputation, I've been driving with my left leg, and so I've had to kind of twist in the driver's seat to get my prosthetic under my left leg and drive with, accelerate with my left foot. And over the past 6 months, I developed sciatica to the point where I needed to have surgery about 6 weeks ago. So I'm wondering, could that have caused this sciatic pain? And that's it. Could this be the cause of what that
It definitely could be. I mean, easy to say part of the cause. Whether it was the cause, it could have been. Definitely the twisting motion, and again, offsetting yourself, putting too much pressure on that nerve. What kind of did you have a back surgery? Is that what you ended up with? Yeah.
Yeah. Was it a was it a microdiscectomy? Was it a
Yes.
nation? It was, so it was a microdiscectomy. Okay.
Okay.
You made mention of it beforehand, that you had the injury a while ago. You compensated over the years with it there. I agree with Danielle. This is probably a part of it. Have you considered the idea of maybe having the car modified, or having some of the driver rehabilitation programs doing more hand controls at this point?
Yes.
Something you consider?
I've considered using, and I'm planning to do a left foot accelerator
Okay.
modification to the truck. Yeah.
The issues with those, and I think you're probably finding this as well, is that quite a few of those are out of pockets at this point. There's a lot of it that aren't
Yes.
covered.
Yeah.
But again, all those different things from a medical standpoint, that I know I can speak for myself with it there. I could definitely make a medical justification with and for that. But if it's something that you would like to have with the card there too, I think it's more than reasonable.
Yeah. Thank you.
Thank you so much. Okay, we're running short on time, but I would love to have Mr. Smalls go ahead, and then Erica, you can get us back into the chat.
Okay. Well, first of all, I want to thank each of you for having me. I don't know if I've been in this meeting, but I was invited by Dean Glassman. My name is Ronald Smalls. I live in Miami, Florida, and I have a above the knee left leg amputation, also a heart and kidney recipient. So one of the young ladies that answered my question when she was, it was Daniela, when she was talking about the scoliosis, and I was going to ask her, is it inevitable for everyone that has a above the knee that's using one leg to get scoliosis? Because like I said, I'm fresh. My amputation was in February of this year. My heart and kidney transplant was done June of this year. And I heard someone mention that they uh uh were just coming home. I've been in the wheelchair for the last 4 months, but I've been in the wheelchair also for the last 4 months, fighting the same thing. I think I heard one of the other gentlemen mention about insurance, because my insurance doesn't deal with the hospital that I was dealing with. So now I got to find another insurance. So I'm going through that as well. But I think she answered my question when she was talking about the scoliosis. Like I said, because I'm above the knee, left leg amputee. And
Yeah, Mr. Smalls, I think you make a good point. You know, there's this chronic compensation pattern that happens for people to be able to ambulate. And I'm certainly not the expert in this realm, it's physical therapy, but that question of like, is all compensation bad, right? Like, and so I've worked with some structural integration therapists in the past that have chosen to intentionally not correct certain compensations because it would then affect other things that I kind of needed to walk. And so I think the best way to answer that is that, you know, having someone that knows your physical body and your musculoskeletal system and how exactly you're moving, they can give you the most sound guidance. But I'm so glad you're here, and I hope you keep coming back. I'm glad that you
yes,
came
I will.
tonight. Go
Thank
ahead.
you.
Go ahead,
Thank
Miss Erica.
Okay, thank you. So Kayla says, I struggle sitting because of the hard socket, and seating is rarely accommodating. Any advice?
Ooh, good question for the team. Danielle, do you got anything? Because that's a problem for a lot
I
of
was going to
people.
see if Paul wanted to jump in, but well, there is potentially, if you want to talk to your prosthetist about having a window put in that can make it a softer socket where you would sit. So that is a potential option. Other options that I've given patients that, you know, maybe it's their first socket, they're not going to get a new one for a little while, or they can't get that window put in, is actually getting little wedges. You can find them on Amazon that they're higher on one side and they kind of angle down on the other side, and they kind of carry them around with them in their, you know, backpacks. They fit pretty nicely. And they use those on different seat areas. I'd say the hardest place, I will tell you, is probably the restroom. I can't say I have a huge secret on that. If maybe somebody else that has a prosthetic above the knee can speak on that. But those are always a little tough because they're built the way they are. But yeah, so those are usually my recommendations. Or some people will carry like a folded up towel and they put it underneath the other side so that they level themselves out. So those are other little things.
Thank you so much. I know we're out of time. I want to be respectful to our specialists that have likely been working all day and have stayed late to be here tonight. I am so excited about this partnership and this collaborative educational opportunity. I've gotten a lot of direct feedback through messages on the chat already about just how excited and enlightened and educated people feel, and I'm really excited to continue something like this in the future. Dr. Tower and your team, Keith and Joanne, thank you guys for coordinating this, and thanks to all the amputees that came out for this hour to invest in themselves and invest in their health. We hope to see you again next month, and we hope that you have a beautiful Thanksgiving, and thank you all again so much for being here.
Do me a favor, Tina, don't close this straight away so that I have time to take notes on the chat, okay?
Yes, and also it'll come through as a file too, so you should be good.
Okay, great.
Thank you, Tina,
right,
for setting this up. We appreciate it there. And it's a lot of feedback that we can take for ourselves there too and utilize and integrate it with our patient care. So it's very, very helpful. Thank you.
Yeah, well, thank you. And you know, for providers that have been doing this for so long and to be in the trenches for so long and to be still so compassionate and so progressive that you're you know, joining late night Zooms with a bunch of amputees that you don't know. I just got to commend you and your team for really putting the health, you know, the care in healthcare. I feel like some of that is lost along the way, but it's refreshing for me, and I'm sure a lot of people here that that it's not lost entirely. So thank you all.
Thank you.
Thank you so much, Tina. Really appreciate it. Thank you, everyone.
Good night, everyone.
Bye, Jenny.
Thank you.